Hello, welcome to Trusted Medic Coaching. I am your host tonight. I'm Joshua Crawford. Tonight's topic is going to be on pharmacology. Obviously, there's no way I can cover all of pharmacology in one night, but what we're going to do tonight is I'm going to lay the foundation. I'm going to show you how when you know more about the basics. When I say basics, I mean down to the cell. See, the thing is most people in medicine, they just learn these random facts, like they just learn these random dots worth of information, but nobody teaches you how to actually connect the dots. And so that's one of the things that you're going to see me do tonight. Um, so, in fact, let's just go ahead and jump right into it. Let me first tell you a little bit about me. So, for those of you who don't know me, once again, my name is Joshua Crawford. I've been in healthcare for 2 decades. Over those 2 decades, I was an EMT intermediate many years ago. I became a paramedic. Then I went on and I became a paramedic educator. I taught paramedic school. After then, I went to critical care school, became a flight paramedic, flew on a helicopter for a few years, and then I went to medical school. So I have worked at various levels over the years. And so I promise you, for those of you who continue to walk with us, I promise you I'll be able to help you. Okay. And so the way this is going to go tonight, first, I'm going to kind of lay the foundation, lay the framework of why you want to know more, why you want to level up your knowledge and go to another level. Then I'm going to show you some basic foundations that, hey, if you don't know the basic stuff, it's going to be hard to understand all that advanced stuff. And then you're going to see how I take that foundation and actually apply it into pharmacology. All right. So with all of that, let's jump right into it. So I'm going to the iPad and we got a lot to cover. So if at any point you need me to slow down, just let me know. Just if you guys will pop a note in the chat for me, I'll be periodically monitoring the chat. And so if you'll just let me know. All right. So with all of that, let's jump right into it. Everybody ready? All right. So let's go. So first things first. Now, why do you want to level up your knowledge? Okay, so I'm going to start. If for those of you in some of the other rooms who have seen me do this before, or you're for those of you who are in our boot camp, obviously you've seen me do this before. For those of you who are just coming on now, perhaps you've never seen me do this. So let me just take just a moment. Boot camp guys, just hang tight for just a second. So there are 5 levels of learning. How many levels? I want you guys talking back to me. How many levels of learning? Or at least give me a hand. Okay, how many levels? There are 5 levels of learning. Now, as I'm asking questions, make sure that you're talking back to me. Make sure you're answering questions with me. Okay, so 5 levels of learning. All right, so watch this. And if you want to take notes, that's fine. Here's what I'm going to encourage you to do. Really watch me so that you get the story down. You don't necessarily have to spend so much time taking notes. I just want you to kind of get the flow of the information. 5 levels, right? One, two, three, four, five. Okay. Most people, when they come into the field, everybody starts out at level one. Level one is where you know the what. Okay. So for instance, let's say in the case of cardiology, I may show an EKG and I'll say, what is this? You say, oh, I know, teacher, that's monomorphic. Or I'll do something else and I'll say, what's this? And you say, oh, I know what that is. That's called VFib. That's where you just know what. So you're able to just recognize things that somebody has told you. Level two knowledge is where you don't just know what it is, but then you know what do the protocols say do about it. Okay. This is the level. Hang on one second. Okay. This is the level where most people stay. They come in with level one or level two knowledge. But here's what I want you to know. Let's say you're taking the National Registry for those in EMS. Let's say you're taking the NCLEX for those in nursing. You're taking the USMLE if you're going on for your doctorate. What you're going to find is all of these exams, all of them, they only test, do you know the minimum level? Okay. So basically, they say, do you at least get to the minimum threshold? Now, but remember, there are levels to everything. Those exams, though, only say, hey, do you know the bare bones minimums to be safe? They're not seeing, are you a superstar? Do you really know what you're doing? They say, do you meet the minimum threshold to be safe? And here's what you're going to know. Some people meet the minimums on their first attempt. Some people meet the minimums on their second, third, fourth, fifth, sixth attempt, right? Now, there's nothing wrong if it takes you more than one attempt to pass. If it takes you 3 attempts to pass, there's nothing wrong with that. But what I want you to know is even when you pass those exams, you're still coming out at the level of the minimums. But here's where most people get to. So they start a program with like no knowledge, and then eventually they get up to the minimums, right? And then right out of school, maybe you go just a little higher than the minimums. And then what happens is you just get out there and you start working. And then over time, what happens is your knowledge actually goes back down. And sometimes it'll even go below the minimum threshold. Now, how is that possible? How is it that your knowledge goes down after you've been working? Anybody have an idea on that? Type it in the chat. Type it in the chat for me quickly. How is it that your knowledge goes down and you've been working longer? Give me a quick answer in the chat. Okay. All right. The boot camp people say complacent. Okay. That happens. Yeah, you get comfortable. In some of the other rooms, what do you got? All right, give me something quickly. Well, let me tell you, it's where you get a lot of times you just get burnt out, you get exhausted, you're tired. And so what happens is you're out there working, you're running all these calls and things like that. And you don't, the last thing you want to do is learn some more stuff. So I commend those of you who are here tonight who decided to come and level up your knowledge. I commend you for taking that extra step to become better. The reason most people stay at just above the minimums or they get worse is because what actually happens is as you're going along and then you've been in the field for a little bit, then what happens is you're working hard and all of that. Eventually, this is what it would look like. So let's say this is 2 years. This is year one, this is year two. Oh, let's go back to the screen. So let's say this is year one, this is year two. What happens with most people is you work a year, and then you work that next year, and finally, at the last minute, you hurry up and try to get you some continuing ed hours really quickly, right? And that's all the continuing ed you do for like 2 years is whatever you can cram in at the last minute to try to renew your license. And that's the story of most people. But let me show you what happens if that's how you approach healthcare. If you start off with the minimum amount of training, then you do the bare bones minimum of continuing ed. You have the minimum amount of education. Would you ever, what's the likelihood of you getting to maximum pay? What's the likelihood that you're going to get to maximum pay, but you have minimum knowledge, minimum continuing ed, minimum education, right? Now, see, most of us we want a great lifestyle, and a lot of people, especially in EMS and hospitals, will complain that hey, management stinks. They don't look out for me. They're paying me the least amount of money possible. Well, think about it. If you were the owner of that company, would you pay you more at your current level? Okay, would you pay you more with the same level of value that you offer? See, you don't get paid based on your personality and all of that. You get paid based on the level of value that you offer your organization, that you offer your company. I want to show you something. I'm coming back to this levels of learning in just a moment. There are 4 levels of value. How many levels of value? There are 4 levels of value. Okay, so watch this. This is about to blow your mind. And wait till we get to the pharmacology part. I'm just laying the foundation. 4 levels of value. Level 1 is what's called implementation. Implementation. This is basically where you do the thing, whatever the thing is. So you're going to kind of use your muscles to make money. Now, some of you have to do really physical work, and yes, you're having to use your muscles. In EMS, the work is like lifting patients, things like that. And so, yes, you're actually using your muscles. Okay. At this level, the most you'll probably make for most people is about $100,000 a year. Okay. And that's in the US. We actually have, boot camp, we actually have somebody here from the Philippines tonight. So, the most at the bottom level, at the implementation level for the US people, you're going to make maybe the highest on average is about $100,000 a year. The next level up, so what I'm talking about is the levels of value. And I'm saying you want to become more valuable as a person to your organization, and that's how you're able to make more money. The next level up is what's called unification. This is where, at the unification level, this is where You're like the manager, the supervisor, things like that. So basically, you use your management skills to manage the people who are doing the thing. Okay. At this level, you may get up to maybe $250,000 US, like at the highest end. Let me show you where the magic happens. Watch this. Above this line is where this is where we separate people who go to really high levels in any field from those who remain at the average, below average, mediocre levels. Okay. And see, most of us have never been taught this. The third highest level of value is something called communication. Talk back to me. What is it? What's the third highest level of value? The third highest level is going to be communication. This is where you use your mouth, okay? Or you use your words, whether those words are written, like in the case of an author writing a book, or you're physically using your mouth, maybe you're talking, maybe you're singing, right? So the people who become excellent communicators, like, listen, guys, I'm actually communicating right now, right? The people who are really good communicators, this is where you separate yourself from the masses. This is where millions start to be made. Okay. If you want to make more money, if you want to become more valuable, you have to operate at a higher level of value. You can't stay at this implementation level your whole life or this unification level. You've at least got to get to the communication level. This is where millions start to be made. And then the final level, the highest level of value, is what's called imagination. Okay, this is where you use your mind. This is where you learn how to think differently. As we get into the farm tonight a little more heavily, I'm going to show you how I think about this information based on what's going on with the cell. Okay, so everybody good so far? There are four levels of value. Let's go back over that quickly. The lowest level is implementation. This is the bottom rung where you do the stuff, whatever the thing is. The EMT, the paramedic, the nurse, the doctor. It doesn't matter, but you're still kind of at the bottom rung, so to speak. The next highest level is unification. This is where you manage the people. The third highest level is communication. This is where you talk to the people. And then the fourth highest level, the highest level, is imagination. Okay. Now, there are two kinds of people. So remember, we're talking about why is it that in EMS, most people don't make enough? They don't know enough, and they're not as valuable in the marketplace. Okay. I'm not saying they're bad people, they're great people, but it's just the market pays you based on how valuable you are. There are two kinds of people. Watch this. Okay. Two kinds of people, or two categories of people. One of them is what are called functional. Okay. Functional people. These are the people who basically do a task. Okay. The EMT, they give the medicine, they load the stretcher, they drive the ambulance, the paramedic starts the IV, they do the intubation, they do a task. Functional people are very replaceable. Anybody could do it. Anybody who has that level of training could do that same job. Does that make sense? A functional person does a task. You want to be not just functional, you want to be vital. A vital person, this is the person, they don't just do a task. This is the person who does more of the thinking. Okay. You want to become the vital person in every industry you're in, on your job, in a business, whatever. You want to become the vital person that is kind of the mastermind behind how things are running. You don't want to just be stuck working on tasks. Okay. Now, I want to go back to everybody still with me so far. Wave at me. Wave at me. Let me know you're still with me. Okay, now let's go back to, I said there are 5 levels of learning. Number one is where you know the what. Number 2 is where you know what do the protocols. Number 3 is where it gets fun. This is where you start to learn the how and the why. Okay. Number 4 is where you're able to apply it to other stuff. And then 5 is where you achieve true mastery. Okay. Most people stay down here their whole career. You want to at least get to level 3 in your knowledge where you understand the how and the why. Now, in order to do that, in order to understand the how and the why, we're going to go back to the basics. And then from there, I'm going to build out the story and I'm going to show you how the pharm ties into the basics. Okay. If I go straight to the medicines, um, it's going to be hard for you to really understand. Now, give me an example. What was her name? The young lady from the Philippines. Let me see. Let me find her again. Lizelle? How do you say it? Lizelle? Okay. So give me, for instance, give me a medication that you're familiar with. Let's just pick one for me. Any, it doesn't matter. Just pick one. You said aspirin? Okay, cool. Let's use aspirin. Okay, so aspirin, watch this. So aspirin also, oh, I'm sorry. And remind me if I don't show something on the screen. So aspirin, also known as acetylsalicylic acid, okay? So just from the name, number one, we already know that it's an acid, okay? And I'm gonna tell you why that's important to know here momentarily. Tell me, give me all the side effects that you know of aspirin. Now, let me help you out. So I did that on purpose. Let's first start to figure out what kind of drug is aspirin. How does aspirin actually work? So aspirin has four main functions. How many functions? Okay. Stay unmuted with me. I want you and I are going to do this together. Okay. So there are four functions of aspirin, or four functions of aspirin. Do you happen to know how aspirin works? The four ways that aspirin works. That's okay. So number one, aspirin works as an anti-inflammatory. So it deals with inflammation. Aspirin is an anti-inflammatory drug. Okay. What else is aspirin? Aspirin is also for analgesia, so for pain. So we know that it works for inflammation. We know that it works for pain. Okay. What else? How else does aspirin work? Aspirin works as a antiplatelet. Okay. So this is, for instance, in the setting of clots. What we're trying to do is prevent more clots from forming. And then what else does aspirin do? Do you have an idea? So anti-inflammatory, analgesia, antiplatelet, and pain, inflammation. I'm drawing a blank right this second. Uh, it'll come back to me. I'm actually drawing a blank right this second. um, but so, but in order to know how aspirin works, yeah, first you have to actually understand the prostaglandin synthesis pathway. Prostaglandin synthesis. Okay. Now, so aspirin, the way it actually works is it binds to something that is along this prostaglandin synthesis pathway. There are these enzymes. One is called COX-1. COX stands for cyclooxygenase. Okay. So aspirin irreversibly binds to COX-1. It also binds to COX-2. So cyclooxygenase 1, cyclooxygenase 2. These two things are what are responsible for pain and inflammation. Okay? So the way aspirin works is it works somewhere along this pathway for prostaglandins. But if you don't understand prostaglandin synthesis, it's hard to figure out, well, why are we doing aspirin? Because one of the things is further down this pathway, this is where clots are going to be. Oh, I'm sorry. This is where clots are going to form. Okay. So aspirin is going to work, for instance, on cyclooxygenase 1 and 2, but then further down this pathway, it's going to work on clots, or it's specifically going to work on platelets to prevent clots. Okay, I'm gonna use a different example as well. Now, let me go back to, okay, so that was a good example. That's aspirin. We're going to come back and I'm going to show you how to tie all this together. In order to really understand pharmacology, we first have to understand a cell. So here's what we're going to do. We're going to go on a field trip inside the cell. Everybody with me so far? We're going into the cell. Let's dive into the cell. So first, let's orient ourselves to the cell itself. We've got a cell. We've got a, for instance, we've got a nucleus. We've got a nucleolus. Okay, they're lysosomes. We have, for instance, we've got mitochondria. We have like the Golgi apparatus. We've got the smooth ER. We've got the rough ER, things like that, right? Those are just the basic organelles of a cell. Who remembers that? Lizelle, do you remember that? Okay. Now, on the outside of this cell, there's a cell membrane. The purpose of this cell membrane, and this is important, I'm going to show you how I'm going to tie a lot in by just knowing the cell. You're going to see how I'm going to come back to the cell, so that's why I'm showing it to you first. Around the outside of the cell, there's a cell membrane. The job of the cell membrane, so what I've drawn in orange here, the job of that cell membrane is to keep some things in and then keep other things out. Now let's zoom into this membrane for a second. Let me just show you what this membrane actually looks like. Watch this. So this is the membrane. We have these heads. So we have two layers. It's called a phospholipid bilayer, meaning there are two layers. Let's break that down. Phospholipid. So the phospho part tells us that it has phosphates. So that's going to be phosphates. And then the next part says it has lipids. That's fats. Okay. Now, here's what we know. Phosphates have a negative charge. That is what causes the membrane to have a negative charge. It's also made of fats. So, watch this. We have these heads and then we have tails. Okay? Two layers. We have a layer of heads and then a layer of tails. Well, it's head, tail, head, tail. Well, here's what I want you to see. The part that's kind of on this, what I'm drawing in blue here, this is the part that's facing the water. So this is the part that loves water. This other little section right here, this is the part that loves fat. Oh. This is the part that loves fat. Okay. Now the word, do you know what the words are for that? If it loves water or if it loves fat. Here, let me just go ahead and tell you. If it loves water, that's called hydrophilic. And fat does not like water. So the fatty part or the fatty section, we would call that hydrophobic. Okay. Now, why did I go through all this thing about the membrane of a cell? Do you know that every single drug that exists is going to behave like a water soluble drug or a fat soluble drug just based on the structure of a cell? So every drug is going to behave like a water soluble drug or a fat soluble drug. Those are the options. There aren't like 20 options, there are two. Okay? It's going to behave like a water soluble or fat soluble. It's going to behave like an acid or a base. Those are the options. Okay? Now, when it comes to every chemical is either it functions like an acid or it functions like a base. Now, when it comes to acids, hold on. It's either going to function like an acid or it's going to function like a base. Okay? Now, when it comes to acids, we have strong acids, we have weak acids. When it comes to bases, we have weak bases, we have strong bases. If you had to guess, most chemicals that you put in your body, whether it's food that you eat, drinks that you drink, medicines that you take, which of these things would you say most things are? Are most things strong acids, weak bases, or strong bases? 90% of chemicals that we put into our body in some way or another, what category would they fall in? Which one of these is most things in our body? What would you guess? Boot camp, just type it in the chat for me. Okay, let me go ahead and tell you. Most things that we put in our body actually behave as weak acids. In fact, about 90% of all chemicals that the body takes in is a weak acid. Okay, and I'm gonna tell you why that's important. I'm just laying the foundation. So let's just review that. We have a cell. That cell has this membrane around it. The membrane has two layers. It has a water side, and then it has a fat side. We have a side that likes water, and we have a part that likes the fat. Because of the structure of the cell, we now know that every chemical that we put in the body is either going to behave like a water soluble drug or it's going to behave like a fat soluble drug. Now, we said that. Now let's go back to how a cell actually works. So let me draw some cells here. Okay? There are two situations that I'm drawing here. This first one at the top, this first part at the top, this is all cells. All cells have three main phases they have to go through. The first phase is called rest, where the cell is just sitting there, not doing anything, just hanging out. It's at rest. Then there's this other thing called depolarization. Now, sometimes you'll hear words like that in the setting of an EKG, but I'm going to teach it down to the cell, because when you hear things like depolarization in an EKG, when you're looking at the waves and you say the P wave means atrial depolarization, or the QRS means ventricular depolarization. Well, let me tell you what depolarization actually is. Then there's this other thing called repolarization. I'm going to explain every one of them, okay? All cells have three phases. All cells are either they are at rest at some point, then they depolarize, and then they repolarize. What does that stuff even mean? Okay, at rest, the inside of the cell has a negative charge. Now, where does that negative charge come from? Remember the cell membrane that's made up of phospholipids? The phospho has a negative charge. The lipids also contribute to the negative charge. So there's this big negative charge around this membrane of the cell that makes the overall charge inside of the cell very negative at rest. Then during depolarization, what happens is the inside of the cell becomes really positive. So when we say depolarization, the only thing we're saying is the inside of the cell becomes positive. Then there's this thing called repolarization. It's where the inside of the cell goes back and becomes negative again, so that it can start all over again for the next cycle or the next action, whatever the action is. All cells go through three phases. They have rest, depolarization, and repolarization. Rest, they're not doing much. Depolarization, they get all excited so they can be stimulated and then they can go to work. And then repolarization is where things calm back down so they can get ready to recharge and start it all over again. Does that make sense so far? Okay. Now, that's all cells, but there are other cells, for instance, in muscles that are a little different. So muscles, they still like some rest too. Muscles still have to be depolarized, but muscles have to do this extra thing, and that's where muscles contract. Non-contractile cells, so some cells contract, some cells don't contract. If it's a muscle, it has to contract, so it has this extra little step. And then muscles also undergo repolarization. Remind me again, Lizelle, what's the charge on the inside of the cell at rest? Stay with me. It's negative. Okay, cool. During depolarization, what's the charge? It becomes really positive. During repolarization with the R, what's the charge? It goes back to negative. Okay. Now, during contraction, the cell also becomes very positive on the inside. Now, how does the cell become positive? How did the cell go from negative to positive? What happened? Well, so let's take a generic cell, just a plain old plain Jane cell. We have these chemicals or these ions or electrolytes that are some are inside of the cell, some are outside of the cell. That's where they like to live. Inside of the cell, the main one that stays inside is we abbreviate it with a K that stands for potassium. Potassium is the main electrolyte inside of the cell. There are also things like phosphates in here, there are proteins inside, things like that. On the outside of the cell, we have things like sodium, we have things like calcium, we have things like magnesium, we have things like chloride. Okay, so here's what I want you to see. Now, I'm going to erase some of it just to clean it up a little, and I want you to focus on just a few. We're going to get rid of phosphates. We're going to get rid of proteins. Let's get rid of, we'll leave the rest. Well, yeah, we'll leave the rest. So, the main thing I want you to know is the main ion or electrolyte that's on the inside of the cell is what? Potassium. Okay. And then most of these other ones are outside of the cell. Are we good so far? So the question was, how does the cell become more positive on the inside? Well, this is what happens. If I take, oh, and then also on these cells, there are what are called channels. So we have different channels. All right, so watch this for a second. We've got these different channels. Let me just draw some channels here. And then we've got boom, 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 boom. Okay. Now, in order for these things to get inside of the cell, they got to go through a hole somewhere. They got to go through a channel. So, for instance, sodium, the way it gets inside is the sodium goes through a sodium channel. And then now we've got sodium inside. And then calcium goes through a calcium channel. And now we have calcium on the inside. Okay, magnesium is going to go through a magnesium channel, and now we've got magnesium on the inside. Same for chloride and all of that. Well, chloride actually has a negative charge, so let's leave chloride out for now. So the way the inside of the cell became more positive is stuff that had a positive charge on the outside went through a channel and got inside. Does that make sense? So here's what I want you to know. The way most cells get depolarized or the way most cells become positive is where sodium goes inside or calcium goes inside. The potassium is already in there, but when sodium comes in and brings all that positive energy, or calcium comes in and brings all that positive energy, it gets really positive on the inside. Then the cell gets all excited, starts acting crazy, and says, "Hey, I'm ready to go to work." And we call that depolarization. So depolarization is where the inside of the cell becomes more positive, primarily because sodium goes in or calcium goes in. Now, which is which? Let me show you. Here's what I want you to know. I did sodium in red. Okay, so sodium, or here, let's do it this way. Let's do depolarization. What does depolarization mean? It means the inside of the cell becomes more positive. Okay. How does it happen? Primarily because sodium goes inside the cell or calcium goes inside the cell. Here's what I want you to know. We have to know this part to tie it into the farm. 99% of everything, 99% roughly of everything gets depolarized by sodium. That's 99% of everything. Any kind of cell in the body, it's mostly because sodium goes inside the cell. That's what makes the cell excited. But there are times when it's not going to be sodium, it's going to be calcium. And that's going to happen the rest of the time. These are special situations. Those two main times where calcium goes in the cell is one of them is in the atrium or the atria of the heart, and then the other one is the thalamus of the brain. Let me expand that box for a second. Now, the atria, let's talk about it. So here's your heart. Obviously, these two top chambers up here, those are the two atria. So, for instance, we've got the left atrium, we have the right atrium. Together, they make up the atria. Okay? So, we have the atria of the heart, and then we have what's called the thalamus of the brain. So, here's the brain. So, we've got our brain stem with our midbrain, our pons, our medulla. Okay. And then if we look in the brain, we've got something called the cingulate gyrus. We've got the corpus callosum. We've got this thing right here called the thalamus. Then we've got the hypothalamus. We've got the anterior, posterior pituitary. Now, thalamus is what I want to focus on. This one right here. So here's what I want you to know. The atrium is depolarized by calcium. Okay. What I mean is what makes the atria get excited? It's going to be due to calcium primarily. Sodium still plays a role, but the main player is going to be calcium. So anything that you hear, anytime I say anything that sounds like atrium, you just need to hear atrium, calcium, atrium, calcium, atrium, calcium. We're good with that. Okay? Anytime I say anything that sounds like thalamus, thalamic, you need to hear thalamus, calcium, thalamus, calcium, thalamus, calcium. Okay. What is the thalamus? This is the part of the brain that's the relay center for all senses. So the sense of taste and touch and pain and temperature, all the senses with the exception of the sense of smell. The sense of smell, olfaction goes through a different pathway, but all the other senses, basically their dispatch center, their relay center is the thalamus in the brain. Okay. Now, how do we use this information? We're talking about this thing called depolarization. Depolarization is where the inside of the cell becomes more positive. It's either because a lot of sodium goes inside the cell or a lot of calcium goes inside the cell. Most of the time, it's a lot of sodium. So if we're talking about a nerve, it's sodium. If we're talking about a skin cell, it's sodium. If we're talking about a blood cell, it's sodium. If we're talking about most cells, it's going to be sodium. There are two exceptions when it's going to be calcium, and that's anything dealing with the atrium of the heart or anything dealing with the thalamus of the brain. Okay. Now, if we have too much craziness going on, too much depolarization, the cells are going too crazy, they're becoming too positive. What do we call it in different body parts? Well, watch this. If we have too much depolarization happening in the brain, do you know what that's called? That's called a seizure. All a seizure is spontaneous depolarization in the brain. In the cells of the brain, they're becoming too positive because a lot of sodium is rushing in. This is why when sodium levels get really high or sodium levels get really low, now you can have a seizure. This is why we need to understand the lab values of what's the sodium level. When sodium level gets too high, sodium level gets too low, now we have a seizure. What is a normal sodium level? A normal sodium level is going to be 135 to 145, with about 140 being in the middle. So we want a normal sodium level to be somewhere in this range, preferably around here. Okay? So I'm not having to just memorize a lab value. Yes, I need to know the number, but I need to understand how the sodium actually works and why sodium is so important. Sodium get too high, seizure. Sodium get too low, seizure. Okay? Now, almost every part of the brain is going to be depolarized by sodium. Remember, we said the exception is the thalamus in the brain. That's actually going to be depolarized by calcium. Everything else pretty much depolarized by sodium. Okay? Now, what if we're in a nerve? What if we have too much depolarization in a nerve? What's that called? When the nerve just goes crazy, we call that pain. Okay? Okay? What if I have too much depolarization happening in the gut? What's that called? Diarrhea. See how we use these names? But all I'm saying is, I'm saying a seizure is depolarization. Pain is depolarization. Diarrhea is depolarization. They're all depolarization that just comes down to a cell. Okay? But yeah, the brain is in the nervous system, part of neuro. The nerves, same thing, neuro. The digestive system, that's GI. But all I said is depolarization, depolarization, depolarization. I just took one thing. Remember how I said when it comes to levels of learning, we don't just know what something is and what do the protocols say do about it. We learn how it works, and then now we can apply it all over the body. Okay? Now let me show you something else. Is this making sense so far? Okay, let's show you something else. What if we have too much depolarization happening in the heart? What do we call that? Where the heart just starts acting up. It gets really positive and starts going crazy. We call that a tachyarrhythmia. Okay? RH1TH1A. Okay. A tachyarrhythmia, a fast heartbeat. Now, obviously, we have all these different names for fast heartbeats, depending on whether they happen in the atria, at the junction, or down here in the ventricles. Okay? Here's what I want you to know. Remember, I said 99% of all cells are depolarized, become more positive due to what electrolyte? You remember? I'm still, it's due to sodium. Perfect. So, if it's down in the ventricle, do you think that's going to be due to sodium primarily, or is that going to be due to calcium primarily? Ooh, I like it. She says the ventricles is in this 99% of sodium. Check this out. What about if it's a nerve? What about if it's a skin cell? What about if it's a hair follicle? What if it's an eyelid? 99% of everything is sodium. What if it's the thalamus? Calcium. What if it's the atrium? Okay, watch this. So you're telling me that if I have cells up here in the atrium going crazy, what if they happen in the SA node? Where's the SA node located? Is it in the atria or is it in the ventricles? Oh, sorry. The SA node right here. Let's change that highlighter. The SA node, is it in the atrium? This is the SA node. Is it in the atrium or is it in the ventricles? So is the SA node going to be depolarized by calcium or sodium? Whoa, check you out. Okay, so that's going to be calcium. Now, what about the AV node? Is the AV node in the atrium or is it in the ventricles? It is. It's at the base of the atrium. So is it going to be deep? Is the AV node going to be depolarized by sodium or calcium? Whoa, check you out. Okay. Now, what if it's down in the ventricles? What if it's what if you have a pacemaker somewhere in here, anywhere in here, that just starts going crazy? What if you have that exact situation that I just drew? It's going to produce that. That's going to be V-fib. Or what if you have one main pacemaker that just keeps firing? So you got this one guy right here that just keeps firing. That's going to produce something like V-tach. Okay. So when we have a whole bunch of pacemakers firing off at the same time in the ventricles, now we have V-fib. If we have one primary pacemaker that's firing off, now we have things like monomorphic V-tach. But what electrolyte is going to be responsible for stuff down here in the ventricles? Which one? Ooh, she says sodium. Let me show you how we apply this. Remember, level 4 knowledge is where we apply stuff. We take a basic concept. We learn what and what do the protocols say, but then we go to the how and why. And then now we can apply it. Let me show you how to actually apply this. Every atrial rhythm is primarily due to calcium. I don't care what you call it. So, what are the atrial rhythms? Well, we have, for instance, if it comes from the SA node, it could be if it's fast, it could be sinus tach. It could be. We could also have things like multifocal atrial tachycardia, wandering atrial pacemaker, supraventricular tachycardia, paroxysmal supraventricular tachycardia, atrial fib, atrial flutter. Okay? Now, here's what I want to show you. Sinus tach is in the atrium. Multifocal atrial tachycardia, obviously that's atrium. Wandering atrial pacemaker, that's atrium. Now, supraventricular. Well, if we have, here's your heart, and these are the ventricles. Supra means above. So what's above the ventricles? That is atrium. So supraventricular is also atrial. Paroxysmal, that means it comes and goes. Supraventricular is also atrium. Obviously, atrial fib is in the atrium, and atrial flutter is in the atrium. What did you just see here? You heard atrium, 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 atrium. Watch this. What if I showed you that the drug of choice? Okay, check this out. What is the electrolyte that's responsible for depolarization in the atrium? What's that electrolyte called? So if I have calcium going inside of the cell of the atrium, the cells in the atrium, I have a whole lot of calcium going in. And because I have all this calcium, it's making everything go crazy. What is something I could do to block calcium from going in? Watch this. Remember how calcium was going in through a channel, and that's how calcium gets on the inside of the cell, especially if we're talking in the atrium? Well, what did it go through to get inside? Ooh, you're saying that calcium went through a channel to get inside. What if I block the channel of calcium? Would that be called a calcium channel blocker? What? Whoa, what if I block a calcium channel with a drug called a calcium channel blocker? Now, check this out. What if all atrial arrhythmias or all atrial tachyarrhythmias are primarily due to calcium going inside of the cell? We call that calcium influx. If I block the calcium channel, that should take care of the atrial problem. Well, what if I told you that the treatment for every atrial tachyarrhythmia is a calcium channel blocker? But I didn't have to memorize that. I just understand the cell, and I don't have to memorize, oh, wait, for AFib, we need to use a calcium channel blocker. No, all atrial problems, we're going to use a calcium channel blocker because the atrium is responsible for calcium or depolarization. Depolarization of the atrium is due to calcium. Okay. Now, when it comes to these drugs, we have this thing called the Vaughan Williams classification system. So it looks like this. So we have things that are what are called class 1 drugs, class 2, class 3, class 4 drugs, okay? Class 1 drugs are what are called sodium channel blockers. I'm going to skip 2 for a second. Class 3 drugs are what are called potassium channel blockers. Class 4 drugs are what are called calcium channel blockers. Channel blocker, channel blocker, channel blocker. Okay, so we have sodium channel blockers, potassium channel blockers, calcium channel blockers. Class 1, class 3, class 4. And then class 2 drugs are what are known as beta blockers. Okay? Beta blockers. So they're going to block a beta receptor. Now, watch this. So you just basically told me that every one of these atrial problems, we're going to use a calcium channel, and now you understand why. Does that make sense? Can you tell me why we're using a calcium channel blocker for all the atrial problems? And you didn't have to memorize it. Based on the cell, can you tell me why? Perfect. Awesome. Okay, now watch this. What about these ventricular problems? So, what about things like monomorphic V-tach, V-fib, things like that? What are some? What's going to be the primary electrolyte problem in a ventricular tachyarrhythmia? It's going to be sodium. So you're saying that if sodium is going into these cells, and I need to stop sodium from going into those cells, what kind of drug would I use for these kind of problems? What? Okay, she says a sodium channel blocker. Oh boy. Are there any drugs that are sodium channel blockers? What about a drug called lidocaine? Huh. Lidocaine is actually a class 1. It's actually a class 1B, class 1 Bravo sodium channel blocker. Lidocaine is a sodium channel blocker. The reason we use lidocaine in ventricular problems is it works on sodium channels and the ventricles are depolarized by sodium. Easy enough? Now, what are some other drugs that are sodium channel blockers that also have this cane ending? Well, things like xylocaine, benzocaine, novocaine, okay? All of these canes are sodium channel blockers. Your beta blockers, your class 2 meds are going to be your ou'lls. So that's going to be things like metoprolol, labetalol, esmolol, sotalol, propanolol, right? All of these ou'lls are beta blockers. Now, what are drugs like? What are some examples of potassium channel blockers? Well, that's going to be drugs like amiodarone. Amiodarone is a potassium channel blocker. However, amiodarone is a wonder drug that's a little too aggressive because amiodarone not only does it work on potassium channels, amiodarone works on sodium channels, amiodarone works on calcium channels. Okay? So, now check this out. Let me show you how we apply stuff like this. If amiodarone works on potassium channels, it's going to go wherever potassium channels are. They're everywhere. What are potassium channels? So if we go back to our cell, remember how potassium was already on the inside of the cell? Potassium is going to leak out through these leaky, well, that's supposed to be blue, through these leaky potassium channels. Okay? Now, so if, for instance, if amiodarone works on potassium channels, it's going to go wherever there's a potassium channel. But if it works on sodium channels, it's going to go wherever there's a sodium channel. Wait a minute. Where did we say there's a sodium channel? Oh, everywhere, like the whole body. So when we give a drug like amiodarone, because it also has an effect on sodium channels, it's going to block nerves. So it's going to affect nerve impulses. It's going to affect function of just about everything. But because it blocks calcium channels, oh, now in the heart, it's going to have an effect on the ventricles, which is why we give amiodarone for ventricular problems. Okay? But amiodarone, because it also works on calcium channels, it's going to go wherever there's a calcium channel. In the heart, that's going to have an effect on the whole atrial muscle. It's going to have an effect on the AV node, the SA node. Does that make sense? So amiodarone can literally have an effect on the entire heart. It can affect the SA node. It can affect the AV node. It can affect um, all throughout the atrium. It can affect all throughout the ventricles. Amiodarone can actually affect the entire heart, but it may affect it in a bad way. Now, I want to go back to something. Remember how I said, see, this is why you must know the basics. Remember how I said, going back to the very basics of a cell, this cell membrane, due to the cell membrane having these two layers, a water part and a fat side, everything is going to behave like a fat soluble drug or a water soluble drug. I'm about to blow your mind. You've never heard this before, more than likely. Those of you in boot camp, I haven't actually taught this to you yet. So, everybody, just take a deep breath really quickly. Take a deep breath, let it out. Deep breath in, let it out. Okay, now I'm going to blow your mind.